The last topic in hypertensive disease of pregnancy is HELLP syndrome. HELLP syndrome stands for H, hemolysis, EL, elevated liver enzymes, LP, low platelets. So hemolysis, elevated liver enzymes, low platelets, HELLP syndrome. This is probably a subclassification of severe preeclampsia. And here's our case. A 32-year-old multigravida, 32 weeks gestation. On a routine prenatal visit, her blood pressure was 160/105. Now what's interesting, you can have HELLP syndrome without hypertension. Her previous blood pressures were normal. Her preeclampsia workup, where we drew blood tests, shows elevated total bilirubin. That would be an indicator of intravascular hemolysis. LDH is elevated, and that is often seen with hemolysis. ALT, AST, so we have elevated liver enzymes, and her platelet count is below 100 to 150,000. So she's got all three: hemolysis, elevated liver enzymes, low platelets. No headache, no visual changes. She's at 32 weeks. We're going to manage her aggressively. Intravenous mag sulfate, prevent convulsions. Induced labor, oxytocin amniotomy, if possible. Lower the blood pressure to between 90 and 100 diastolic with hydralazine or labetalol. And there is one other recommendation with HELLP syndrome, and that is to give the mom dexamethasone, not to enhance the fetal lung maturity, but to promote normalization of her liver function tests and of her platelet count. So that's going to be the management for HELLP syndrome. This table looks at the incidence of abruptio placenta, and normotensive patients and mild preeclamptic patients do not have any difference in abruption placenta. But notice severe preeclampsia, 10% of patients, eclampsia, 11%, chronic hypertension, superimposed preeclampsia, 15%, but the highest risk of abruptio placenta is HELLP syndrome. Okay, let's summarize what we have just said. And this is our table. Our differential diagnosis is in the middle. Criteria for diagnosis on this side. Management is on this side. Notice proteinuria. No proteinuria, sustained elevation of blood pressure after 20 weeks. Diagnosis, gestational hypertension. If it is uncomplicated, conservative outpatient management. Chronic hypertension may or may not have proteinuria. Hypertension either prior to 20 weeks or pre-pregnancy. Management uncomplicated is conservative. If you need to use any medication, we're going to use alpha-methyl-dopa. If she has known chronic hypertension with blood pressure getting worse, proteinuria developing, that's chronic hypertension superimposed preeclampsia, this is what I call aggressive management. Inpatient, mag sulfate to prevent convulsions, lower the blood pressure to between 90 and 100 diastolic, and deliver by the appropriate route. If she has eclampsia, hypertension, proteinuria after 20 weeks, unexplained seizures, management, aggressive. If she has maternal or fetal jeopardy, plus hypertension, proteinuria, when I'm saying maternal fetal jeopardy, we're talking about end organ effects. Headache, epigastric pain, visual changes, elevated liver enzymes, DIC, oliguria, cyanosis, so on. She has severe preeclampsia. Management is aggressive. Mild preeclampsia, hypertension, yes. Mild proteinuria, yes, over 20 weeks, but no maternal or fetal jeopardy, no headache, epigastric pain, visual changes, DIC, elevated liver enzymes, etc. Management will be conservative if she is preterm, less than 36 weeks. If she is 36 weeks or more, give magnesium to prevent convulsions and deliver by the appropriate route. And that brings us to the end of this chapter on hypertensive disorders of pregnancy.